Hi, how are you guys doing? So while I was away, a lot of you requested me to go through a lot of topics. So let me start with the most requested topic, how to run a code blue. So we have different types of codes, including code blue, code purple, code orange, code 10, but our focus today is on code blue. So what is a code blue? This is a hospital emergency that indicates that a patient has gone into a cardiac arrest, respiratory arrest, or any medical condition that requires emergency resuscitation. So the first point that I want to make is when a code is called, you literally have that person's life in your hands. This is the time that everyone needs to work together to achieve the same goal, which is achieving ROSC, return of spontaneous circulation. So before we actually dive in what you need to do during a code, let's do team roles. So a code must comprise of a code blue team. This team is allocated daily before the beginning of shifts. So this team includes the team leader, the compressor, the pulse checker, the one that will check the pulse, the one on the airway. Will also include the recorder, the family liaison, and the one who is giving orders. So a team leader, this is a person that literally runs the code. He analyzes the rhythm in the code and advises on the medications to give the patients. He coordinates and delegates tasks to other team members. So if you're a team leader, you are not supposed to do any other activity because you need to maintain your focus. You are also one who ends the code. So number two is the compressor. The compressor can really be anyone. The main focus here is to perform effective CPR. So be ready to do compressions for 2 minutes. When you're tired, shout for help. Someone is right behind you, ready to take over. It is a very strenuous activity. The bed should be adjusted to suit your height, or you can use a stepping stool. When you're switching, do not immediately get off the chest until the person behind you verbally indicates that he or she is ready to take over. So most important, do not stop CPR until you are told by your team leader. Points to note, compression rates are 100 to 120. Allow chest to recoil. Depth 5 to 6 centimeters, and that is 2 inches. I'm talking about an adult patient. Minimize interruptions during chest compression. Hands should be placed in the center of the chest at the lower half of the sternum. Then use both hands and arms straight with shoulders directly above the hands. Next is the pulse checker. It may sound silly to list this one as a role, but I can't tell you how often I've been in a code where no one knows who's gonna check the pulse. This leads to time wasting, which shouldn't be the case in a code. When checking the pulse, only utilize the carotid and femoral pulses. This person can also be doing other tasks other than pulse checks as long as they are ready for the next pulse check. Next are the runner nurse. The runner nurse should be at least 2 nurses doing this. So these nurses administer medication as per orders. They check the random blood sugars and also check the vital signs. So next is the recorder. The recorder can be anyone, but a nursing staff is preferred. They note when the code starts and when the code ends. They note down the medications that were given, if pulse checks were done, and other interventions. So the team relies on this person on the correct timings of pulse checks, that is after every 2 minutes. Also, when medications are supposed to be given, but sometimes we have pharmacists who do that, especially with epinephrine, which is given after every 3 minutes. Next is the airway. Here it depends with your facility. Mostly it's the intensivists, doctors, in coordination with the nurses who manage the airway. So start bag mask ventilation right away if the patient isn't ventilated. So have tools ready for ventilation because the perfect time for ventilating the patient is during a pulse check. Not delay CPR in order to ventilate, just resume bag mask ventilation. He will also get a peripheral access, or CVC will be better at this point. Next is the family liaison. This person reaches out to the family once the code happens to both update the family and to inform them of the code status. The physician and the intensivist should also talk to the family. In any code, there should also be a reviewer of orders. This person checks the file, the orders, the laboratory investigations being done, the radiological investigations being done, and relaying this information to the team leader and placing orders as ordered by the team leader. They may also be analyzing this case with the team leader. This person should be the physician, the primary physician, or the intensivist. So points to note, codes are messy, but our aim is to run a smooth code in order to achieve ROSC. So make sure the AED, the defibrillator, is properly hooked to the patient if the patient would require a defibrillator. Have a backboard placed under the patient during a pulse check. Then have someone check the code status of the patient. No one wants to accidentally code a DNR patient. Check the H's and T's. These are the common causes of cardiac arrest. The H's include hypovolemia, hypoxemia, hydrogen ion, this is acidosis, hypothermia, hypoglycemia, hypokalemia, and hyperkalemia. The T's include toxins, tamponade, that is cardiac tamponade, tension, for instance, tension pneumothorax, thrombosis, that is coronary thrombosis, pulmonary thrombosis, then trauma. So codes are stressful. As a team leader, always encourage your team. Always remind them of the strong work they are putting in to bring this patient back to life. So common questions asked, how long should I run a code? You will have varying answers on this. So 20 to 30 minutes is okay. So if the patient has not achieved ROSC within the 30 minutes, discuss with the code team if they have any other suggestions on interventions, and if not, stop the code. As we all know, the longer it takes to achieve ROSC, the more likely the patient will have irreversible anoxia, even as soon as 4 minutes post-code. Always support the family. So, the code is over. Now what? So if the patient has achieved ROSC, return of spontaneous circulation, support the patient. If the BPs were low, start the patient on inotropic support. Keep the patient clean. Start the patient on mechanical ventilation. Nutrition should be at par, etc. And if the patient died, call in the time of death and the recorder should note that down. Cover the patient respectfully prior to relatives seeing the patient. Do last office and pack the body for morgue. Lastly, do a debrief with the team. Discuss what went wrong and needs improvement, and also what went right. So, parting shot, your clinical cheat sheet in Code Blue should include the following. Always check the random blood sugar. Do not forget the input-output chart. Do not stop compression when the AED, the defibrillator, is charging. Always stop or only stop when the shock is being delivered. Always check the H's and T's during CPR. You may be able to intervene and achieve ROSC quicker. Avoid slow codes. Identify code status ASAP. Most importantly, after a code, it's always good to reflect. Don't beat yourself up of the poor prognosis that you've achieved. As much as we want to save everyone, we can't. But that doesn't mean we don't work as hard as possible for that patient. Always know that you did your best. So what I'm sharing here is based on my experience in the facility I'm working in. You may have a different way of how you handle codes. Kindly leave a comment on how you do it at your facility. So until next time, see ya and bye. Did I say bye? So before you leave, I just wanted to tell you I'm running an Airbnb. It's called Brickers Lavish Living. It's located in Kisumu, Milimani. If you have someone who's visiting Kisumu and needs somewhere to stay, kindly contact us. We'll really appreciate. Thank you and bye.